Assalamu alaikum wa rahmatullahi wa barakatuh. My dear professors, my great honor to joining you in this valuable meeting. I speak today about the TransCarotid Artery Revascularization, the TCAR, the game changer for management of carotid diseases. The TCAR is a minimally invasive hybrid procedure for treating of high-grade carotid stenosis, and it combines both the surgical access and the endovascular stenting, and the unique for using the temporary reversal blood flow in the carotid artery to protect the brain from the emboli, and this small incision just above the clavicle allow direct access to the common carotid artery. The cheese that inserted into the common carotid artery has an external flow reversal system, and this system deliver the blood from the carotid artery away from the brain and filter it from all the debris and return the blood again to the femoral vein. And by this unique reversing flow technique, the crossing of the stenosis and dislodgement of the plaque traveling into the filter instead of causing a stroke. The TCAR is typically performed under local anesthesia and sedation or general anesthesia according to the patient condition. The surgical access is 2 centimeter incision made at the neck line just above the clavicle. The common carotid is exposed and directly cannulated and usually positioned below the plaque. The match of venous sheath which placed percutaneously in the femoral vein. Initiation of flow reversal that the surgeon clamped the common carotid artery proximal to the sheath and connected the arterial sheath to the venous sheath via an external filter to flow as a circuit, and this pressure gradient, which is higher in the carotid artery, lower in the femoral vein, direct the blood backward from the carotid through the filter. Before any intervention, corrode the lesion. A high rate reverse flow confirmed and maintained to ensure neuroprotection. The carotid stent placement with flow reversal guide wire, either balloon or stent, advanced through the carotid sheath across the stenosis, and the novel here is the en route transcarotid stent that deployed in the carotid artery to scaffold the plaque and widen the lumen, restoration of the flow after stent deployment and after balloon dilatation, and restore normal antegrade flow. The sheath removed and the carotid axis is closed, often directly or with a surgical patch to ensure that everything is away. We are away from the aortic arch. This is a sample video for the reversal flow system that direct the blood directly from the common carotid artery to the femoral vein, and the blood is filtered totally in the filter. About the indication and patient selection for the TCAR, the patient with significant carotid stenosis who are candidate for carotid revascularization and of high risk for a stroke. In general, the same degree of stenosis that indicated for carotid endarterectomy can be treated with TCAR in the form of either symptomatic patient more than 50% or asymptomatic more than 70% according to the NASD criteria. But the key patient selection is the high-risk patient, that severe cardiac disease, that patient severe COD, severe renal failure, age above 80, and these patients are not tolerate the hemodynamic stress of carotid endarterectomy. Also, the adverse neck anatomy as the hostile neck, cervical spine immobility, high carotid lesions, or presence of tracheostomy, and also the TCAR small incision at the base of the neck avoid extensive dissection for this scarred area. The contralateral carotid occlusion or cranial nerve palsy, that the carotid endarterectomy had a higher stroke and nerve injury risk to the contrary of TCAR that provide an alternative approach. Either asymptomatic or asymptomatic, that the symptomatic patient with recent TIA or stroke, and asymptomatic patient with high-grade stenosis can be treated with TCAR. And according to the guideline of the SVS in 2021, that allowed the asymptomatic carotid more than 70%, either carotid or TCAR, or transfemoral stenting may be chosen provided that the center preoperative stroke and death risk is less than 3%. For the summary, for the indication for the patient, that the patient prime candidate for the TCAR at the high risk for carotid endarterectomy, and the procedure done in a center with experienced operator, and the preoperative imaging either by duplex or CT8 to confirm that at least 5 centimeters of the common carotid length from the clavicle to the bifurcation is safe for sheath placement. About the comparison between the TCAR and carotid endarterectomy, that the carotid endarterectomy has been the gold standard for surgical management for the carotid diseases and established a high efficacy. The TCAR is less invasive according to the data, and the preoperative outcome for the TCAR can approach that of the carotid endarterectomy. Some key comparison that about the invasiveness, the incision for the TCAR is small, about 1 inch at the root of the neck instead of a long incision of the carotid endarterectomy, and with less surgical trauma, and the patient recover faster in the TCAR and go home next day, or versus 1 or 2 days after the carotid endarterectomy. About the anesthesia, both can be done under local or general anesthesia according to the patient condition, but the TCAR tends to have a shorter operative time than carotid endarterectomy by about 30 minutes. About the neuroprotection, the carotid endarterectomy shunt used to maintain the cerebral perfusion instead of the TCAR neuroprotection by flow reversal system without clamping for a prolonged time. About the preoperative stroke risk, we found that the 30-day stroke rate for the TCAR is about 1 to 1.5%, and according to the Roadstar trial that report 1.4 stroke rate in a 30 rate in patient with TCAR. And the long-term stroke prevention also appears similar in both data between the TCAR and the carotid endarterectomy for about 2 years. The Roadstar trial is a 30-day trial for the safety and efficacy study for reversal flow that using during carotid artery stenting procedure. And about the cardiac affection and cardiopulmonary affection, we found that the TCAR avoid this prolonged arterial cross-clamping, and the CREST trial for carotid artery stenting versus carotid endarterectomy showed that the carotid endarterectomy had a higher rate of MI than stenting procedure, and is likely hold true with the TCAR as well. About the cranial nerve injuries, the carotid endarterectomy has a possible rate of affection for the hypoglossal, vagus, and facial, about 5%, while the TCAR had a 1% cranial nerve injury. And about the durability, that the early data suggests that the TCAR had a lower restenosis rate over the carotid endarterectomy, and in comparison that we find that the more than 80% restenosis at 2 years, with 3 after TCAR and less than 1% after carotid endarterectomy. About the comparison between the TCAR and the usual carotid artery stent, we found that it addressed the pitfall for the carotid artery stenting. About the access route, that TCAR is a minimal invasive access route, avoiding the aortic arch manipulation, and it has a cerebral protection device by the proximal flow reversal system. And about the procedure data complication, the TCAR may have a higher rate risk of local site at the neck, but it's much more higher than the transfemoral groin complication as bleeding and pseudoaneurysm. And about the systemic complication, the superior stroke safety profile of the TCAR made it preferred in stenting method. And also in the patient selection, we endorsed the patient with high risk, that high risk and patient eligible for endovascular intervention away from arch navigation issue. In summary, we found that the TCAR combined advantage of both open surgery and stenting. It's better embolic protection. According to the SVS, recommend the carotid endarterectomy over transfemoral carotid artery stenting in more than 70%. And finally, we found that the TCAR is a valuable alternative for the carotid usual or transfemoral carotid artery stenting. About the ESVS in 2023, we are more cautious, noting that while TCAR is promising evidence from randomized trial and needed before fully endorsing as the primary alternative to carotid endarterectomy. The clinical studies that done for the TCAR, the Roadstar and Roadstar 1 and Roadstar 2. Roadstar 1, it's an FDA trial for the TCAR, prospective, single-arm, multi-center, high-risk patient, done on 141 patients. For 30-day stroke rate was 1.5, outcome for the MI or death in 30 days with 3%, no intraoperative stroke, and all the stroke, which is the 1.4, reported to the lowest reported at the date of the carotid stenting. Very low cranial nerve injury, about 0.7, and excellent outcome. About the Roadstar 2, it's a post-approval study, more large than the Roadstar 1. It done between 2016 and 2019. over 632 patients, and the majority of the surgeons that performed this procedure with a new to TCAR, 30-day outcome that the stroke rate was 0.8, and the combined death, stroke, and MI was 1.7, 4 minor strokes, 1 death, 6 MI, and no patient has a stroke-related death.
Please to conclude دكتور مصطفى. لا هو كان بادئ غلط، هو عدينا ال10 دقايق.
Okay, about in conclusion, the TCAR, and with the recent development, we have to broaden and train much more training for this technique. We have to expand the indication for this technique. The RCTs is highly needed in this technique for the level evidence one based. The use of enroutment system is the novel of this technique. And my conclusion that the TCAR represents significant innovation in the carotid artery disease. Roadstar 1 achieve excellent outcome with a stroke rate 1% or less, and we look to the future and ongoing research for this technique. Finally, we are experienced players. We can do surgery, we can do TCAR, we can do carotid endarterectomy. The patient condition that leads us for the best for him. So we can do anything, but we have to choose the best for the patient. This is a very small video for the process of the TCAR. Very small incision in the base of the neck, control of the common carotid, insertion of the sheath, closure of the common carotid, and start the flow reversal system directly to the femoral vein. شكرا.